We have plenty.
Yeah.
Also, there's an event in here beforehand, and I think we have some leftover pizza as well. So otherwise, thank you everyone for coming. And of course, for Joia for showing up. And we can go ahead and get started. Evan, do you have the video running? Okay, great. So Rudolf Virchow, who can be considered the father of social medicine, once claimed that the physician is, quote, the natural attorney for the poor. And in my opinion, few have embodied such a radical yet necessary role as a physician as much as Dr. Joia Mukherjee in her championship for global health equity. If you particularly are in the mood for self-humbling, you can just search or Google Joia's current position titles. For example, Chief Medical Officer of Partners in Health, Advisory Dean of the Peabody Society at Harvard Medical School, Associate Professor at Harvard Medical School, Professor in the Division of Global Health Equity at Brigham and Women's, Director of the Global Health Delivery Program at HMS, and visiting faculty at the University of Global Health Equity in Rwanda. Yet these titles only hint at the impactful track record that Joia has as a leading voice in the field. After completing her medical education, Dr. Mukherjee took her career to rural Uganda, where she focused on HIV prevention, and then finished her residency at MGH and doing a fellowship in infectious diseases. Since 2001, she served as a Chief Medical Officer for Partners in Health, collaborating and working with local communities in Haiti, Rwanda, Lesotho, Malawi, Sierra Leone, Liberia, Peru, Mexico, Russia, Kazakhstan, and our own country, including the Navajo Nation. She's been instrumental in leading the organization's efforts to mitigate MDR-TB, HIV, and Ebola, and most recently the COVID-19 pandemic. She's also worked extensively in the local and international health policy field. She served on the World Health Organization's Green Light Committee on the treatment of voltage-resistant tuberculosis, as well as the Technical Reference Group on pediatric HIV care during the COVID-19 pandemic. In partnership with the city of Boston and Massachusetts, she helped lead contact tracing efforts during the COVID-19 pandemic with the Community Tracing Collaborative. She's also the author of An Introduction to Global Health Delivery, Practice, Equity, and Human Rights, which if anyone here is interested in practicing global health, in my opinion, it's a completely necessary read. And on top of her professional roles, Dr. Mukherjee is a fierce advocate for social justice in medicine, a captivating professor, and public speaker, and a mentor to countless students at HMS, and also a wonderful singer. As with everyone that she meets, Dr. Mukherjee has had a very impactful influence on my own life and my desire to enter global health, as I hope that she will for you tonight. So on behalf of Partners in Health Engage, as well as the Harvard Undergraduate Health Policy Review, please join me in welcoming Dr. Joia Mukherjee. Yeah, you can.
Okay, that's fine. Yep.
Stand wherever you want to.
Oh, and I have this, so I don't have to. Okay, great. Everybody can hear me okay?
I think that's mainly for
the zooming,
video.
so I shouldn't have it on my necklace. Bad form. So I see some familiar faces. How are you guys? Some people took my class last year, and some of my current students, some people I don't know. Great to see you all. So Garrett said I could talk about whatever I want. So what's on your mind? Yes.
NTV Now.
Oh, good for you. Okay, NTV Now. That's easy. I will talk about that. What else?
Garrett just rattled off a really long list
Yeah.
of obligations you have for ways in which you're involved in structural change, but you also practice accompaniment.
Yeah.
And how do you balance walking with people and doing that with kind of the systemic change that might be drawing on your time and attention and is also just as important?
Well, you guys are really focused. That's great. So TB, accompaniment, and TB Act. What else? Nobody wants to hear what I think about the election? I think the election, in a way, is the biggest object lesson right now that we have in global health. So I will talk about that a little bit. Anything else? Any other thoughts here?
Oh, no, I just.
Yes, good, right. Yes.
So for one moment, I just read, started, or, sorry, now that I started a new, like, home hospital care
Yeah.
program for homeless veterans.
Oh, nice.
If you could talk to me a little bit about, like, how, home health might expand health equity.
That's great, sure. I don't know that much about that, or I don't know anything about that program, but I'd be happy to talk about that, yeah. Okay, so that gives us, any other burning thoughts? Yeah, did you have a hand up over there, you're just scratching, yeah.
Your involvement and experiences for Rwanda, through in other countries, or just kind of,
In general, okay, yeah.
Your experiences mentoring students and
Okay.
how that was.
Yeah, awesome. Okay, good. Well, let me start with so our good friend John Green, who's an author. Do we need this on? Can you turn that on?
Yeah.
Great. Everybody know who John Green is? Who doesn't know? Everybody knows. So he's a YA author. He's an amazingly wonderful person. He also runs something called Crash Course and also the blog Brothers with his brother and Nerd Fighters. And the reason I'm bringing John Green up before I bring up any of these questions that you asked is that he has written a book that's coming out in March that is called Everything is Tuberculosis. So I'm going to take that and sort of answer the questions, but talk about all these things. So John is a writer. He's from Indianapolis. He had no experience with health and certainly no experience with tuberculosis. He has been a supporter of Partners in Health now for about 10 years, has done a lot of great things with us, and kind of goes where we tell him to go and learns about it, and has raised a lot of money through his network for different things at Partners in Health. But he started to see tuberculosis the way we see tuberculosis at PIH, which is that everything is tuberculosis. And I always say that tuberculosis is my favorite disease, which is really creepy, right, to say it's my favorite disease, but through the lens of tuberculosis, you can kind of see the whole world and health inequity in it, right? So what do you think is the number one factor that tells you if somebody's going to live or die?
Poverty.
Poverty. Poverty. Like everything is about poverty. So people will tell you that it's behavior, people need to change their behavior, they'll tell you that people don't believe in Western medicine, they'll tell you all these things, but at the end of the day, zip code is the thing that will determine whether you live or die prematurely, right, if you die prematurely. And so when we think of medicine, for those of you who are planning to go to medical school or are doctors or are in medical school, we often think of this very biomedical model of a disease like tuberculosis or, like cancer or like HIV. But in fact, it's not a microbe. It's not a genetic mutation that really results in this inequity. It's poverty. So then the question is, how is it that poverty causes inequity in health? How is it that poverty causes inequity in health? Yeah.
access to resources.
So access to what kind of resources?
I guess medications or drugs.
Medications and drugs, for sure. So the stuff you need to get well, right? What other things? Yeah.
Preventative care.
Preventative care, so like vaccines or clean water, huh? Screenings, right? Yeah.
Access to like fresh foods or like exercise
Food,
spaces.
right? Exercise. Yeah.
Perhaps physicians won't treat them as well.
Yeah, discrimination in treatment, definitely. Thank you, that's great. Other things? Zazie.
Bandwidth.
Bandwidth, tell me what you mean by bandwidth.
in the Soul of Care, Arthur Kleinman talks about a problematic patient that was written off by his physician, like his fellow doctors, and needed a home visit, and it turns out that she had like 3 kids she was taking care of, and like was
So
working
the
3
patients
jobs.
themselves don't have bandwidth to care for themselves. Thank you. Yes, yes. Other things? Okay, so that's a decent list. It's a decent list. It's not the perfect list, right? And the reason it's not the perfect list is because there's a, yes, Priyanka is going to give me the perfect list.
Affordability, so they can afford it.
Affordability, right. So getting in the door, being able to pay. So these are all good things, right? But there is a systematic exclusion of resources that occurs, right? And that systematic exclusion is sort of en bloc, right? So if you live if you're an African American person in Boston, you likely live, you're not at Harvard, you likely live in a town that was redlined, which means, you know, when people were able to get federally qualified, you know, reduced subsidized loans, these neighborhoods that were mostly black and brown were kept out of that, right? And that means what? That means a lack of access to decent education, because education in the United States is paid for by property taxes. It means old lead pipes, because the municipal water supply isn't good enough. It means fewer providers. It means farther away care. It means less people who have health insurance, more people who are not proximate to the health center. So the reason I'm saying those are a good list is we can understand exclusion as a one-off thing, or we can understand that zip code, right, is the thing. And it's because exclusion happens geographically. It happens other ways too, but that's the way we really see it in the very, very segregated world. So that's even true where I work in Sierra Leone, for example. We know there are neighborhoods where it's mostly professional people who are Sierra Leonean and the expats, right? And they have a totally different outcome than the people who live in the village, right? And so within countries, so between Roxbury T-stop on the Orange Line and Back Bay T-stop, that's a 6-minute T-ride, that's a different life expectancy by 20 to 25 years. In Boston, right? Where you could argue we've got plenty of medical care, right? We've got plenty of preventive care. We've got clean water, but it's that systematic exclusion from resources, right? Does anyone know when we say that's what impacts health, that systematic exclusion, what do we call that in health speak? Does anybody know? It's called the social determinants of health, right? The social determinants of health are water, sanitation, income, housing, infrastructure, access to health care, right? And those things, right? So those things are actually rights. If you look at the Universal Declaration of Human Rights, those things are there. The right to health care, right? The right to sanitation, running water, the right to pay a paying job, right? So there were people during COVID, for example, like me, who got paid full-time to sit at a desk, right? I never had to venture out into the COVID world. There were people in a place that we worked called Immokalee, Florida, who are farm workers who live 15 to 20 in a 2-bedroom trailer, and if they don't pick vegetables, they don't get paid. So the isolation and quarantine for people like that is completely different from me, right? So we could say we both have equal access to, let's say, vaccines when they came along, but totally different outcomes, right? And so when we think about the social determinants of health, there are many things that happen, but there's one disease that really is like night and day, and that's tuberculosis, right? You rarely see a wealthy person in a wealthy country, right? Because it's also the pooled resources of the country. So for example, if you're in Sierra Leone and you have a heart attack and you need a cath lab, even if you're wealthy, you may have to leave the country, right? So there's the access to resources in the area you live, but it's also the community access to resources. So people who live in poor communities are doubly impoverished, right? The poor people in poor communities doubly impoverished, right? So the reason we say everything is tuberculosis, right? The reason I say tuberculosis is my favorite disease is there's nothing that cleaves along those lines more. You just, I mean, you know, there's no way Bill Gates will ever get tuberculosis. And me, I have seen thousands of good tuberculosis patients, thousands, in prisons, in slums, right, in factories, and I've never even converted my skin test. Why? Because I eat. Because I've got this and this, right? So, and not to say you can't get tuberculosis. Some of you may be frontline providers, some of you may be from countries where there is a lot of tuberculosis and you may be exposed and you may have a positive skin test, but the likelihood if you're well nourished, right, if you don't live in an overcrowded place, that even that latent tuberculosis will never really flourish, right? So where Partners in Health goes, because we make what we say a preferential option for the poor, we make that preferential option for the poor. We decide on the poorest communities, the most vulnerable people. Tuberculosis is almost always there. And not to say that other things aren't there too, but that is a disease that over and over again has shown itself to be really related to this exclusion from resources. So why do you think that is? What's special about tuberculosis? It's a weird disease, yeah.
It requires multiple drugs to like effectively eliminate.
Right, so you need at least 4 drugs. Even with the simplest tuberculosis, you need 4 drugs. And you have to take them for a long time. So you know you can eradicate a lot of infections with like 5 days of medicine, right? Even 3 days of medicine. But for tuberculosis, you're talking a minimum of 6 months. There are some new regimens that are 4, but 6 months is the minimum. So if you're a person who lives with this side of social exclusion and you have to take a medicine for 6 months, that's going to be hard. Yeah?
Resistance?
Right, so if you don't take those medicines, if you can't take those medicines, or if those medicines aren't available for the full 6 months, then you can develop resistance. That's a whole nother can of worms, where then you have 2 years sometimes of treatment, right, with multiple drugs. So the therapy of tuberculosis is complicated, right? So that's important, but that's not why tuberculosis is so much common among impoverished people.
Isn't it like a third of the world has latent TB, but it only becomes active when you're like malnourished or otherwise?
So malnutrition is a huge factor in the development of active TB, as Ozzy's saying, even probably whether you get latent TB, although that's not really well proven. But definitely we see that people, adults and children who are malnourished will take a latent TB and it just comes to life. And so a lot of the TB that I see in adults is even weird forms of TB because they don't get the usual TB because their immune system can't even kind of pack it in. Usually, like if you have a healthy immune system, even if you get tuberculosis, the immune system just kind of puts it in a little ball and sticks it there in your lung. But when you have a weak immune system from malnutrition, the TB just gets everywhere and it's very hard to detect. So definitely malnutrition is a huge reason that people get active TB and more deadly forms of TB. What else? What else? Waiting for someone else, Ozzy. Yes?
Doesn't tuberculosis require like consistent exposure? So like if you're in a country where like cases are very rare, then it's not as likely for
Not so much consistent exposure, but close exposure, right? So if you are in an overcrowded place, this is why we see so much tuberculosis in prisons. When we do case finding in a person with tuberculosis and try to say, okay, who are their contacts? And you go to home, there's 10 people living in a one-room house, right? In some of the prisons that I work in, there's like one barracks and there might be 150 men, or women, but usually I've been more male prisons than women prisons. So overcrowding is going to increase the chances you get it, right? And so we see it even as a family disease, right? You can see it mom, dad, children, partners, cousins, right? So in that overcrowding, so you have overcrowding, you have malnutrition. What else? Yeah.
Probably something to do with like the kind of work they do. So in poor regions, they might do, for example, like mining, which will expose them to like lung irritant and stuff and make it a lot easier.
Absolutely. Mining. Mining is probably the single most risky disease to get tuberculosis, and we know if we look in southern Africa, which is some places that we work at Partners in Health is southern Africa, Malawi, Lesotho, but in South Africa as well, Namibia, Botswana, Swaziland, tons of tuberculosis. So yes, it's a lung irritant. We know that silica from the dust in the mine does make you more likely to activate TB. But the other thing is you're working deep, deep down in a mine with no ventilation. So it's not only the close proximity, it's the lack of ventilation, right? If you can't open a window, right? So the way, even if we have a patient in the United States with tuberculosis, they go into what we call a negative pressure room. So the air is being pushed out and circulated 12 times a minute. That's what we do here. Now imagine if you're a mile underground, that's not happening, right? So definitely the kind of work that people do, particularly mining, but we've seen, you know, bus drivers in very busy cities, you know, in India and Bangladesh, you know, in very overcrowded places. These are occupational exposures, right? Especially, you're already poor. If you're a miner, you probably don't have a lot to eat. You probably don't live in a very well-ventilated, open-air kind of place. You probably live with many other people, mostly men, and you probably work very deep. So you can imagine the multiplicities of exposures there. What else? Yes, Ozzy, now I'll go to you.
Like HIV.
HIV, right? So HIV, which ripped across the African continent in the 90s and is still there, right? And is also a very huge risk factor for developing tuberculosis, right? So HIV, malnutrition, housing, ventilation, types of jobs, malnutrition. Anything else? Yeah.
This is just an idea, but maybe wealthier countries don't think it's a problem because they don't have it, so people don't really donate.
Ding, 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 right? So we got no money for tuberculosis. It is the top killer of adults in the world, right? And nobody really cares. Like, we tried to amp up the hysteria. This is not something I would do. I don't want to take any credit for this because I don't like this kind of approach, but even PIH, for a while, we called MDR-TB Ebola with wings because we wanted to scare people. I'm not into the scare tactics myself, but people aren't afraid of tuberculosis. It's not coming here, right? So we know in our psyche that this is a disease of them, not us. Hugely important, and that's why we'll go to the End TB Act. Okay, we'll talk about that in a minute. Anything else that sticks out of why tuberculosis? Well, I would say it's not that easy to diagnose. And so you have to have a health system that is fairly well resourced to diagnose TB. Like, luckily with HIV, you can have a finger stick, not even a blood draw, just a finger stick, tiny drop of blood, you can know if you have HIV or not. We have nothing like that for tuberculosis. So you need at least a microscope. But better yet, you need machines that will grow cultures, you need a kind of genetic test that you do on sputum with a special machine. So the access to that higher level of care is not available in most resource limited settings or impoverished settings. So in fact, I'll go back to the sort of ideas of the election. We see some of that in the United States, and I'll talk about that as well. But so these are some of the many reasons, probably others we haven't even thought of. But so when Partners in Health, because we choose the to side with the poorest people. Tuberculosis is one of the things that we deal with. And it's not that we only care about tuberculosis, but it is so associated with poverty and oppression that we end up doing a lot of it. So everything is kind of tuberculosis, right? So tell me what the NTB Act is and what you know about the NTB Act.
I think I'm part of Partners in Health.
Good. Tell us about it. Yeah.
And we have been learning about it as a bill that would increase global health funding, globally, not just in the
Right.
United States, to fight tuberculosis.
Yeah.
And it passed in the House and
Yes.
the Senate, which is really exciting. But I think also something that we were stressing a lot in the past few weeks was trying to reach as many members in Senate as we can before the next year.
Absolutely. Right. So really important. So we need more money, and we need more money for all these things, right? We need more money for case detection for sure. And that we can do with X-ray. Most places don't have X-ray. We're even using AI in places like Lesotho where there's very, very high volume. Most places don't have the digital X-ray so that we can enable AI. You need these genetic testing machines called Gene Expert. You need to actually grow cultures, which is the gold standard, and that's what we do in the United States for everybody who has TB, right? So that's just diagnosis. Once you get diagnosed, you've got to figure out not only the treatment, whether it's the more simple treatment of 6 months or the longer treatment of 9 months to 24 months, you also need to figure out what are the social determinants of health that you need to address to get that person well. Because often it's food, right? And you want to go to their house and make sure that everybody who might have been exposed also is tested. And then we have another protocol if they don't have TB but they've been highly exposed, we can give them preventive therapy, right? So that whole package, and then you want to walk with someone, which Zazie was talking about, accompaniment, to make sure they finish their therapy and they have what they want. So what is accompaniment saying? Tell me what your life is like. How can I help you? You walk with them. You understand their journey, right? You really understand what are their barriers. Is it money? Do they need just cash to get to the health facility? Do they need food? Do they need support for their children, right? So the whole so we could end TB. TB is completely treatable, but we have chosen politically not to end it because it doesn't affect us, right? TB rates started dropping like this in the 1940s before we even had treatment in the United States because people were moving from cities into suburbs. Right? So just having quality of life space is enough to improve. So really we need economic development, but in the meantime we can alleviate a lot of harm by treating TB in a comprehensive way. So the reason that our PIH engaged colleagues have worked on that is to say we have some new drugs, we have new treatments, they're actually not bad, they're well tolerated, they're easy, but we still need the money to do this whole package because the drugs alone is not going to be sufficient because this is a social disease, right? So that's kind of how we think about our work at Partners in Health. So you mentioned Peru, right? When we started, so Partners in Health started in Haiti, as some of you know, and we treated everything. So anyone who comes in the door, we try to figure out what they have and treat them. So we occasionally treat a person with cancer. We treat a lot of women who are pregnant who needed a safe delivery. And we treated lots of people with tuberculosis because in the area we work, Haiti is very poor in that place. There's a lot of tuberculosis. So that all was going on the regular. And we were invited by a parish priest to go to a small community in Peru, an asentamiento slum. And we thought, oh, it's good, there will be no tuberculosis here. Because Peru had the best TB program in the world. Okay, are you Peruvian?
Yeah.
Yeah, all right, so they had the best TB program in the world. And on paper they did. But as we're in this slum, we started seeing case after case after case of very severe tuberculosis. And I mean severe people that had TB for 5 years, 10 years. Their lungs were like erased, totally scarred, skinny people, not able to breathe. And we thought, what is going on? Well, the one size fits all was that anyone who got tuberculosis got these 4 drugs. Some of those people were resistant to those 4 drugs, but there was no other alternative. So you just kept treating them over and over again. Some of the patients we saw had been treated 6 times, 7 times, same drugs. And then what do doctors do? Do you know what doctors do when patients over and over again still sick?
Blame it on.
They blame the patient, right? We say, oh, those people, those Peruvians, they don't take their medicine. They don't understand. It was actually we that didn't understand. Those patients had been infected with resistant strains, and there was no option for them. So they were living in overcrowded areas, and they were spreading that drug-resistant TB to their families. And so there was a lot of secondary TB because the medicines were stocked out to resistance and people would develop resistance, and then they would spread it to their family, which is primary resistant TB, because the first time you even get it, it's resistant already, right? So that work in Peru actually is what led us to expand, particularly weirdly, to Russia and Kazakhstan. Because in the former Soviet countries, they were dealing with an epidemic of drug-resistant TB from the collapse of the Soviet Union and other things, and stockouts, and lots of social issues. Like Russia had good TB control, and then the Soviet Union collapsed, and all hell broke loose in terms of TB because there was massive inequality, displacement, devaluation of the currency, incarceration. So all these things happened, and then so we were invited there because we were one of the only organizations that was treating the resistant form of TB, which we started to do in Peru. And everyone said, it's dumb, let people die, it's too expensive. I know, right? Like, it's shocking. It's shocking. And I had just finished my ID fellowship here, infectious disease. I was telling I'm always kind of like this, like really animated. I was telling my best friend, who is, the ID doc at the Mass General, they're treating these resistant patients with the same thing over and over again, and it's the WHO regulation. He said, oh, come on, Joy. It's like, really? He didn't believe me. It seemed like so crazy and so absurd. So in Russia and Kazakhstan, we also showed that you could treat drug-resistant TB. You had a question.
Are you still meaningfully in Russia today?
Yeah, we are. We've had to separate the organization that we started in Russia to be its own Russian NGO. We don't have a lot of channels of communication. We were actually kicked out of Russia by Putin in 2000. It was during the Obama, maybe 12. But the Partners in Health Russia is still working. Yeah. So that sort of put us on this international stage for doing something that was like sort of obvious. Like people had resistant TB, they were dying. We had the drugs. I mean, resistant just means resistant to the 4 most common drugs. But there's plenty of other drugs. Because we were doing that, then we got into these international debates, because Partners in Health was tiny. Like when I started in 99, it was like 200 people. And most of them were in Haiti, and like 5 people in the US. And suddenly we're being invited to these international conferences, mostly to get punched. Right? I mean, literally, somebody from the WHO said, I will physically aggress you. Imagine. I'm like 5'3". But we won that fight. We won that fight in a way because we had different allies, especially, people living with tuberculosis who are not as good as the next allies we had, because a lot of them are really, really poor, right? So it's hard to be an activist when you can't eat, right? Some people do it and they're amazing. But we won that fight. Finally, enough evidence came that the WHO changed their policy and we got to treat drug-resistant TB as a normative thing. But meanwhile, go back to Haiti where I said we just took anyone who came in, right? Lo and behold, some of the people coming in, a couple of them had HIV. So similarly, we said, oh, this is a treatable disease. Let's treat these people. Wrote a paper, just just a couple years after the Peru paper showing we treated MDR-TB. Again, we're tiny, we have 50 people on treatment, and oh my God, everyone said this is the stupidest thing. It's gold-plated, it's not sustainable, Haitians are never gonna take their medicines, Africans don't wear watches, all kinds of things. You can't do that. Now, these drugs were donated to us, and they were non-expired, and they were donated by a place called Cambridge Cares About AIDS, which was mostly gay men who had switched off a particular therapy and went on to another therapy, so they gave us their unexpired drugs. Even the Wall Street Journal wrote an article about the guy, he was an undergraduate here, who brought the HIV drugs in a paper bag to Haiti. He was called out by name in the Wall Street Journal. Why? Evil Sanjay Basu. He's taking drugs in a paper bag to Haiti for 50 patients. Why would the Wall Street Journal care? I mean, the Wall Street Journal never cares about Haiti. We treated 50 patients. They all got better. Yeah.
What year was this?
Probably 98, 99.
Oh, okay, so it wasn't like during the RSD, like, well,
What's RST?
no, ARSTI.
RST. It probably was during RST. I don't remember. Was not RST related though. Because the Wall Street Journal also doesn't care about President RST. Wall Street Journal, what does the Wall Street Journal care about? Money. So why would they care about Sanjay Basu and his paper bag? Because it's free. Because we were giving the drugs out for free to 50 people who are not their market, by the way. Right? They're peasant farmers. Peasant farmer means you hoe, you dig, you eat. That's it. You don't have money, you barter. Right? Your kids may or may not be in school, but these are like the poorest people on earth. And we're saying, you know, your life is worth something. We're going to treat you so you can return to your farm, so you can take care of your kids. The Wall Street Journal is mad that we are providing these drugs for free. And why those drugs and not the TB drugs? Because at this time, by the way, in these years, there's about 20 million people in sub-Saharan Africa with HIV, 20 million, right? And we had the drug, the cocktail from 95. So in 95, 96, 97, 98, 99, 2000, 2001, 2002, 8 years, 8,000 people died a day for lack of antiretrovirals. So we've got 50 things in a paper bag. Why would the Wall Street Journal take that on?
Was this at the same time as, like, Brazil and compulsory licensing?
They were patented. So the TB drugs weren't patented. Nobody cared about them. They weren't patented. These drugs were unpatented, right? And so that launched us into a whole different fight. Like, so the TB fight for PIH was just like, do the right thing. The HIV fight was do the right thing and change the system, which is a different fight, actually, right? So we had to look at trade regulations and patents and work with other organizations that have lawyers and understood how you can bring drugs in that are patented, yet if it's a national emergency. And so we ended up doing a lot of advocacy for that. And we won that fight, and that was the most miraculous fight, and that was mostly activists, people living with HIV in the global north and the global south, standing together. And we were a small part of that fight because we were the only ones who had treated a handful of patients. So they could say, oh, look, they did it. We can do it too, right? So the movement was huge, and it was 99% people living with HIV. And so brave. You know, people are living in countries where they could have been killed, and they would wear t-shirts, I am HIV positive, shut down conferences, embarrass politicians. Meanwhile, people with more education were like suing the governments of South Africa, of, you know, this and that. drug companies are suing governments. Merck sued the government of Ghana, right? I mean, this was such a fight, you can't even imagine. But we actually won, and that is how we ended up in Rwanda, Lesotho, because in Haiti, when we won, and the winning was something called the Global Fund to Fight AIDS, TB, and Malaria, and the President's Emergency Plan for HIV, AIDS relief, those two were suddenly billions of dollars that had never been there for global health. So prior to that, there was no money. So the only thing you could do is like vaccinate and give vitamins, but suddenly do you guys know the saying, the dog caught the car? So like, you know, there's like dogs chase cars, and they never catch the car. But like, we actually caught the car. Because we said, we need these drugs, we need them. They said, okay, here's the drugs, here's the money. But then we had to say, oh, how are we gonna find everybody, right? And so today, global health as it is really comes from that fight. Because once you have the mandate to treat AIDS, TB, and malaria, then you need laboratories, then you need nurses, you need doctors, you need clinics that are decent, right? So the notion that some of you may have heard of health system strengthening, that comes from this period of building up in response to this fight and catching the car, right? So that's our work in Haiti. We got the money and said, you know what, we had this little clinic I told you about where we just did whatever. But we said, okay, now we have millions of dollars we never had. We are not going to invest them in this little charity clinic. We're going to invest them in the public sector. So we started supporting public facilities across Haiti, and we said our case-finding strategy, because we didn't care about AIDS. Remember, we just did whatever, right? We said our case-finding strategy is primary health care. If you provide medicine for pneumonia and for diarrhea and for mental illness and for hypertension, if people understand that healthcare is available to them, is free, then they'll come, and you can look for TB, you can look for HIV. But if you just go out and put out a sign, nobody cares, right? Especially poor people, because they're working too hard. They're only going to come to you if they're sick. They can't afford it, right? So that work of using primary care as our HIV case-finding strategy, we said HIV was our battle horse. The battle was against the lack of health care. The battle was against the health inequity. The horse was this movement for HIV treatment, where we sort of convinced people that we could absorb the money, we could use it, we could deliver on the promise of universal access for HIV, which we have today. Right? Today, there are 37 million people on the planet who are getting treatment for HIV with antiretroviral therapy for free. You can go to rural Mozambique and get antiretroviral therapy, right? You can go to the mountains at the top of Swaziland, Eswatini, and get antiretroviral therapy. So that, but those places are not just giving out antiretroviral therapy. They're also taking people's blood pressures and making sure pregnant women are getting their antenatal care, right? So that is the health system strengthening. So because Partners in Health did that in Haiti, and no one had done that, generally NGOs focus on their mandate, and that's it. We call that vertical, right? But we said, no, we're going to do this in a horizontal way through building primary care. And so African governments said, we want that. We don't want a bunch of American NGOs coming and saying, we're going to do this, and we're going to do this, and we're going to do this. We said, no, we want a partner to help us build our health system, and by the way, find HIV. Because even in the worst case scenario, which in the world is Lesotho, 26% of the adult population has HIV, it's still not even the majority. Right? So the majority of people have something else, and they still need healthcare, right? So that's why we were invited to Rwanda, Lesotho, Malawi, because we had this, one, support of governments, and two, the idea that whatever money was not for one disease, it was for a health system. And if you built a good health system, you would meet your vertical targets, right? If the health system's good, you can vaccinate everybody. If the health system's good, you find cases of diabetes, right? So that was sort of that, and so the work that I have done mostly as the chief medical officer is trying to work with our teams on the ground on a strategy, right? So we have lots of different ways that we try to get to universal access to health care, cash transfers, making sure we have enough in the cupboard, making sure our healthcare workers are well qualified. But it's in the question that Sazi asked about accompaniment that we are the most unique, right? And I think it's very, very important to understand what that is. So when we say accompaniment, again, Partners in Health, we say our mandate is to make a preferential option for the poor, which means side with the most vulnerable, the poorest, the most left out. To get to people who are struggling, you need to be there. You need to be proximate. You need to walk with them. You need to hear their stories. You need to learn with them. And when I say you for us is a very, very big team of people, and most of them are also poor people. So our team around the world, 1,700 people, 17,000. 11,000 are community health workers or other community members. So it's people helping other people, but we enable them to do it by giving them training, paying them, making them part of the team, and learning from them. Like when I'm in the field, which is pretty regular, I always go out with our community health workers because I want to see what they see. I want to see what is the condition of this patient's house. What does the school look like? Are people able to access water, right? Because again, those social determinants, they're not theories, they're things. They're material things that people need. So it's really our accompaniment, which is this proximity, walking with people throughout their journey. That's what really allows us to get equity, right? So if you look at our outcomes for our patients living with HIV, in Lesotho, even in Haiti right now, they're better than they are in Boston. They're better than they are in Boston because our patients have help, right? They have accompaniment. They have people who care if they miss a dose of medicine or if they can't get to the clinic. So I'll just sort of wrap up by saying, that's what we do is holistic care, not one disease. The global health movement is really built on the backs of this AIDS movement, but we need to do more, push it farther. In most of the countries we work, we do this holistic thing. A little less in Peru because we started really mostly as a tuberculosis Peru, Kazakhstan, Russia. But then to understand that equity means addressing the social determinants of health, right? There is no equity without that. And to do that really requires you to have constant feedback loops, eyes and ears, and really love on the ground where you're paying attention. If somebody says they need X, you believe them, right? You don't say, well, no, I think you need more isoniazid. If they say, I need a goat, say, okay, let's try to get, I saw a guy last time, or a few years ago in London, a man was there in the hospital with his child who had just an absolutely destroyed heart from rheumatic fever, which is basically strep throat that was untreated, okay? The guy had been sitting there for months, and his kid was dying. And I said to our team, he needs a valve. He needs 2 valves, actually. Let's try to get him to India. And I was like, no, we can't do that. It's too expensive. I was like, get this to, if it was your kid, would you want them to be sent somewhere? So we got this kid to India, and I was there when he got back. He looked amazing. He looked like a totally different person. His dad was ear to ear smiling. And his dad said to me, he's my best friend. You saved my best friend. And what I said to this man was, tell me what you need to get your family back on your feet, because he had been sitting at this boy's bedside for 6 months, and he's the breadwinner. He said, I sold all my goats. I said, we will get you your goats back, right? I mean, so this is you can't then, now you've treated this thing, but the family's going to be 10 times more impoverished because now they have no livestock. So So I know, it's like, makes you cry, right? It makes you cry. You should see the pictures of me picking up that kid. I was so excited. But you know, this poor man, like, he wasn't even gonna ask. He was so grateful that his kid was alive. But it's on us. And why did I know that? Because I have accompanied people, right? I had been to his house. I had met his wife. I knew they were struggling. I've accompanied other people because we have community health workers, you know? So we got this guy a bunch of goats. We paid for the other kids to go to school, and everybody's good. I mean, they're not great. Like, they could be doing better, but compared to, right, this catastrophic illness claiming a person in the family and impoverishing the family, right? So now we have a live kid and a not impoverished family. So that's a good outcome, right? So, you know, that's the kind of work we do. And I think when we think about policy, we cannot think about health policy without thinking about social and economic policy. So the last thing I'm going to say is just about the election. Do not for a second think this is about Trump. Do not for a second think this is about Trump. Every single thing you hear, well, not everything, most of the things you hear are Trump as a talking point of this Project 2025. And the Project 2025 and the what we call neoliberal capitalism, which is the thread of that, okay? The policies behind that are to privatize everything. So when we say get rid of the Department of Education, that means it will become private schools. When we say get rid of the NIH, that means private companies will get research dollars, right? When we say get rid of the FDA, that means less federal regulation. So everything, most of the things they're doing are from this neoliberal playbook to rob people of social and economic rights. Which are the social determinants of health? Rights, right? And so try not to get into the circus carnival Barker thing and really pay attention. Now there's a couple other things like criminalizing LGBTQ folk, like abortion. I think those are not strictly from the neoliberal playbook. My personal view is those are a distraction from the real thing, which is moving money to wealthy people. I think those are a distraction. It's a way to gin up people, you know, stigmatize, scapegoat people. You know, it's the fault of the trans people. It's the fault of the immigrants. It's the fault. But meanwhile, the house is being robbed. So this is what I think. Other people have different ideas, but pay attention to that privatization theme, because I think that's what's going to do us in. And when I talk to my friends from Africa, this is what they've been living with. This is what was imposed on African countries by the World Bank, the IMF, since 1978. And I'll tell you, the results are disastrous. So that's all I'm going to say about the election is, like, let's not make this about Trump. Let's make this about neoliberal capitalism and the dangers to our social and economic rights, and our other rights as well. But I think the social and economic rights are the ones that are the most critical. And my kid is trans, so like I want them to go to college in Canada. I mean, like, don't get me wrong, it's a real threat to women, it's a threat to LGBTQ folk, but I still think the main thing they want to do is rob us of our social and economic rights. Okay.
Minutes for questions, so yeah, take it away if anyone has any questions.
I have the Socratic thing, so a lot of you already answered questions or asked questions, but
I have a quick
yes.
question. So you're talking a little bit about how the beginning of partisan health was kind of almost this battle against like the status quo from the World Health Organization and these kind of rules that are put in place. But also you have experience consulting with the World Health Organization.
Yeah.
So what's it like being involved in those battles, but also kind of partaking in this health policy system?
Great, it's a great question. For those of you who are interested in advocacy and policy, what you hear from our colleagues around the world, the great activists like Greg Gonzalez and others, that there's always an inside strategy and an outside strategy, right? So you want to protest, you want to storm the barricades, but sometimes it's important to be inside so you can change policy. right? So both are needed, and it depends on where you are in the struggle, right? So in the beginning, when we're just proving the principle, we're outsiders. But then you start to say, oh, some people get it, and you get moved inside. That doesn't mean you're co-opted, because if you can change the policy, now you can get co-opted. So it's important not to, and I think the reason we're able to hopefully not get co-opted is we still stay really close to the patients, and so many of our colleagues are poor people. They're gonna keep us honest, right? But so like with my work at the WHO, with TB, we have been fighting, and then we won this battle for WHO to make a committee to help countries establish MPR-TB programs. So sure, I'll sign you up for that, right? Same with HIV. All these people saying don't treat HIV, don't treat HIV, and the WHO decides to write guidelines for countries, like sign me up, right? So it's really about the inside and outside strategy. In a progressive administration or a democratic administration, you'll see that progressive groups will not have as much of an outside strategy. They'll try to work from the inside, if you're Planned Parenthood, if you're PIH. But in this coming environment, we're gonna probably not have any inside strategy, right? Because we're not gonna have the connections to move inside. Some people can do that. I mean, Cole Farmer had a unique ability to even do the inside strategy with relatively, hostile people, but like generally, it's like you're gonna stay on the outside. But that's how we think about advocacy, is those two things as kind of a dialectic. And sometimes you're playing both, sometimes just one, sometimes the other. Yeah, Priyanka.
Oh, thank you, Joya. I'm here actually to ask you one special question. We didn't talk about the neoliberalism today, but I was hoping that. So I was attending this lecture, Rosa Allen Moore lecture, in the Golden Hall, and there was this lady, Daniel. She introduced this concept of power sharing liberalism. She
was it Daniel Allen?
Yeah, and she was actually talking about this, where other also provided the inputs. So according to her, so it can be a good approach. Having the democratic equality right and share the powers among them. But my question was that I asked her, but I didn't get the answer, so I thought to ask you.
Okay.
So my question was
we won't have the same answer.
Well, she didn't answer my question.
Okay, I'll answer your question.
So, do you think having this concept, maybe that can be another alternative for all of the countries, but still it will be first implemented in US, but it will enhance the more imperialism structures around the world, because then the US will again impose this power sharing liberalism to other countries too. And then it will again, I would say, Detroit all of the health equity structures.
I would say, Priyanka, first of all, because I believe in, all education is political, right? That you learn from Paulo Freire, the Brazilian educator, you learn that from Desmond Tutu, you learn that from many people. So my politics are clear, right? I'm a leftist. So my politics are very clear, I'm unapologetic. That doesn't mean you have to be a leftist too, but you need to filter what I say through understanding where I stand, okay? Danielle Allen is not, right? She's more of a moderate. So again, not anything wrong with that, but those are two different takes. My view is who is sharing power, right? If it's a bunch of elites, even elites I love, my own friends at Harvard, right? Or my friends who are doctors in Haiti, if it's a bunch of elites sharing power, it's not gonna trickle down, right? I think goodwill alone is insufficient. Where I've seen real power dynamic is through the AIDS movement, through union organizing, right? Through people who are affected, and us as elites taking our cues from them. That's what I believe. So I don't think my colleagues in Chiapas who are revolutionaries, they said this to me. Don't look up into the left for your solutions. Don't look up into the right for your solutions, look down into the left, right? It's community organizing, listening to people, walking with them, understanding them, and believing them. That will be much more a solution based on equity. So again, I'm not saying Daniel Allen is wrong. I'm saying what I believe is power sharing among elites of different nations is not necessarily going to help the poorest people on the planet.
Yes. Thank you for this answer. And I asked you this question because the actual idea is actually to have an alternative for the neoliberalism. And my point was that, and maybe I might sound rude that time because I asked this question.
Yeah.
So my point was that, but it's not really an alternative for that.
I don't think so either.
Yeah.
And I think liberalism, I mean, again, this, you have to kind of read a bunch of economics, which
private.
Liberalism is really about trade liberalization, is about, like, it doesn't necessarily help the poorest people. It helps us make profit. It comes from neoliberalism, which is less government restriction. Liberalization of markets is to increase profit. So anytime we use the word liberalism in that setting, I'm suspicious that it's trying to get rid of the guardrails of social and economic rights, like of what a government should do. I mean, you could say if we just made the market without the FDA for drugs, like that would be liberalizing the market. But then we'd have a lot of drugs that sucked and were toxic, right? So and that's what's going on. Like, that's what I'm saying. Pay attention. It's a good question, Priyanka, and we have to pay attention when we get rid of regulations. Regulations are usually there to protect people against financial ruin, health harm. You know, when I was a kid, my family was all labor union people, like my mother's side, my white side. All my relatives, my male relatives, were missing fingers, like all of them. And I remember one of my cousins playing the flute, and I started crying because he was missing a finger. He couldn't hold down that one key. And I said to my father, Dad, my dad played sitar, and I said, you're going to lose your fingers, and then you can't play sitar anymore. He said, I'm not going to lose my fingers. I'm a professor. Those people all lost their fingers because there were no labor protections in the 30s, in the 40s, in the 50s. Now, you don't see every laborer with a missing fingers. I mean, it happens, but it's like, those are federal regulations around safety, right? And without those, so you could say, well, that should be liberalized. But the protections that are there, those are not liberal. Those are federal regulations. So this is where I find the liberalizing thing, I'm afraid of it. And I want to see the details. The devil is in the details. So maybe she's got a great plan, and she's a very smart woman, and I respect her. But I would want to see what that means.
Thank you.
Okay, well, we're past time.
Okay.
Everyone, let's give one last round of applause. And there's probably leftover pizza.
Oh, great. All right. Give me a call. I'm happy to come in.